Hello, ladies and gentlemen. Good afternoon. Hi there. Welcome to this public consultation on health services in Oxfordshire, here in Wantage. My name is Gail Downey. I'm a journalist and filmmaker, and I've been asked to chair this public consultation as an independent person. Yes, phones off, please. Thank you. I'm so sorry. There is a difference, I do know. Okay, tiny bit about what's going to happen today. There's going to be a presentation outlining the proposals. The panel are going to introduce themselves, and then there is going to be the roundtable discussions, which is where you are at the moment. There'll then be a summary at the end where we would ask somebody from each of the tables to sum up the key points that you want to make. Will that work? That work for everybody? Yes, no, what? That's all right. Okay, totally good. All right, thank you. Thank you. Okay, there are 3 fire exits, a bit of housekeeping. That one is very obvious. The one you came in through is another one. And there's another one, I think, one of our volunteers is pointing through the back of the kitchen there. And there are also toilets at the back of the building. Thank you, our volunteers are pointing. We're going to have about 20 minutes at the start, after the presentation, for you to ask questions of the panel who are all here. They're all labelled, and they will also tell you a little about themselves and their jobs. So we're going to start with that. Our volunteers have microphones, and they will come to you so that everybody can hear your questions and what you're saying. Obviously, the panel have already got their own microphones, so you'll be able to hear what they have to say. As well. A couple of things. Please, when you're asking questions, let the panel answer those questions, because it is a public consultation and you're here to hear what they have to say. They are certainly here to hear what you have to say as well. Okay, I think that's about it. We will start. So let the panel introduce themselves. We'll start with Diane Hedges, who's from the Oxfordshire Clinical Commissioning Group.
Hello, welcome everyone, good afternoon. My name's Diane Hedges. That's going to be a bit tricky. Hi, Diane Hedges, good...
That's probably better. The microphone's for them to sit down, so we'll just...
Can you hear?
Yeah.
Okay. Good afternoon, Diane Hedges. I'm from the Clinical Commissioning Group, which in effect has responsibility for making sure we buy a comprehensive range of health services within the available resources. I've worked in the NHS for a long time, starting my career in a GP practice over the border in Berkshire.
So, hi, my name is Peter Knight. I'm from the Oxford Hospitals Trust, and I'm the Chief Clinical and Information Officer of the Trust. I've been in healthcare for probably too long to remember, around about 20 or 30 years these days, and predominantly with policy and at the Department of Health prior to this. So that's me.
Good afternoon, my name's Tony Berrant. I'm the Medical Director of the Trust, Oxford University Hospitals Trust. That means I have responsibility out the board for quality-related issues. It also means I have responsibility for issues related to the quality and professional practice of the doctors in particular.
Thank you. Hello, I'm Julie Anderson. I'm a GP and Clinical Director for South West Oxfordshire for the Clinical Commissioning Group. As you probably know, all practices in Oxfordshire are members of the CCG, and my role is to represent those practices in South West Oxfordshire and act as a liaison between the CCG and its members.
Good afternoon, welcome. My name is Pete McGrain. I'm the Clinical Director for Older People Services, and I work with Oxford Health NHS Foundation Trust. I've lived in Oxford since the mid-90s, been involved in the NHS since the late 80s.
Okay, thank you. Okay, so we'll start the presentation and then we'll move on to the questions and answers. We'll start with that, Diane.
Okay, so I just want to take you through the content of the consultation, which is an Oxfordshire-wide consultation. It covers a range of areas which are outlined here. We're out for a 3-month consultation, which ends on the 9th of April. The scope of the consultation is as described here, and I'll take you through some of that. There is relevance in relation to this particular geography, and we'll give that emphasis in relation to that. But this is the clinical commissioning group is responsible for commissioning for the whole of Oxfordshire. So we want to take you through all of those proposals. The board are representative of the whole of Oxfordshire. So some things will feel more relevant than others, but it's important that we get everybody's views. We are currently consulting on the use of hospital beds. Now, to be really clear, that's the use of acute hospital beds, beds that were either in or are either in the Horton Hospital in Banbury, in the John Radcliffe, in the Churchill, or in the Nuffield Orthopaedic. It's very much about how we're using acute hospital beds, and we'll talk through this afternoon how we find some better ways of supporting patient care than using those particular hospital beds in acute services. But I can't emphasise that enough. We will explain as we go through that there are other hospital beds we'll talk about, but that's not part of this particular consultation at this point in time. Planned care at the Horton. So the Horton Hospital in Banbury, we've identified there's a whole range of outpatients and diagnostics that we could manage more closely to where patients live in the Horton, not an impact at this end of the patch. The acute stroke services, so the way in which we deliver stroke care, and for a range of these areas, we'll have a short video clip that will take you through the proposed changes. And this is acute stroke changes, not related to bed-based care either in Abingdon or other areas at the moment. Critical care at the Horton, the way we deliver intensive care, and maternity services in Horton, particularly the obstetric service. So where mothers are identified as needing obstetric care, being of higher risk, the care that they can be provided by an obstetrician, not midwife-led. And I'll explain why I'm emphasising that. We are planning to talk about a wider range of services in future consultations, but there is a limit to what we're consulting on in this first phase of consultation. Why do we need to change? Well, you will have heard an awful lot over the whole periods, I think from Christmas to now, around the way in which health services are challenged, whether it's the level of resource we've got in our general practices through to the amount of pressure that we're feeling in A&E. We're not alone clearly in the national picture of having a range of challenges, and if I may, I'll just pick out some of those different factors that are affecting our need to think again about how we deliver healthcare. And in particular, in this first phase, we will be really looking at how we use our workforce, and workforce is one of our real constraints. The demand on services. Now, the great news we have is that people are living longer lives. The outcomes in Wantage Grove are great. You have better than national average life expectancy. You also have a range of things that need to continue to be managed and supported to support you in that. So the demand on the services is growing for good reasons. More people living longer, but it is meaning we need to, and we can do more things for them. Financial pressure is one of our challenges. Actually, I'd really emphasise, as we're talking about this phase one consultation, financial pressure isn't the driver of change in this first phase of consultation. Better prevention, better quality, and we hope we'll really make the case for you today around the quality of care can be improved, particularly when we think about stroke care, particularly when we think about critical care. There are known ways in which we can get better outcomes, we can reduce the level of disability. Our estate and infrastructure isn't what it needs to be in a range of places, and I know that's particularly, we've got people needing more space in the Wantage Health Centre. We know we've got infrastructure that I know you'll want to talk about at some point today that's affecting care delivery in this area. And we've got inequalities. Even within a Vale area, you will have differences in life expectancy between different wards in terms of what people can expect. So a whole range of things that mean we can't allow health services to stand still. We need to keep thinking how we redesign our health services to, great news, meet the needs, meet the demand, meet the growing elderly population, but we need to keep thinking how we change. So there are two parts of the consultation. I'm sure that this is something that we will talk about this afternoon. But at this point, the reason why we've got two parts to this consultation is there are a range of services that we've had real challenge in continuing to deliver in their current form. This particularly applies to the obstetric services in the Horton, where having the number of obstetricians that we need to make sure that whatever time of day, whether it's a weekend or whether it's the middle of the night, we've got an obstetrician there. We found we cannot keep recruiting. So there have been some urgent changes that we've needed to make in the short term, whether that's at the Horton, around maternity services. We also want to move fast on improving our stroke care and critical care, and I hope by the time you've heard the messages today, you'll be with us around understanding the imperatives that there are around that. In relation to the beds that we've had in the Horton and the John Radcliffe, we hope you'll come with us on seeing that actually some of the changes we've made are really good, and we want to make those changes permanent. The things that we're putting in place, the different ways in which we're managing care. So that is why we've put things in two parts. There are some things that are urgent, that are temporary arranged, that we just need to get sorted in relation to this consultation. There is a much wider range of services that we need to come back out and talk to you all about, including all community services, including the way we deliver our urgent care A&E. But we need to do a lot more work with you at a local level and across all of the localities in Oxfordshire to really make sure when we come out of for the next stage, we've got all of those things understood. So there's some real imperative about the things we want to talk to you about today. In terms of what we want to do for the future, last slide for me, and then I'll pass over to Dr. Anderson. The things that we are laying out as our vision for the future, which we will continue to build on as we talk about the next phase of consultation, is, and you'll hear a lot of this, I hope, this afternoon, there is so much more that we can do by getting the diagnostics in the right places and early on in people's care, supporting our GPs to make and support people to stay in the community where it's appropriate. We use the phrase, the best bed is your own bed, wherever we can use diagnostic support, clinical support, ambulatory care, which is in effect walking into care, walking out from care and getting your diagnostics and assessments in between. All of those ways mean that we can support more and more people and keep people at home. And the really striking thing that I don't know if you've heard before, but certainly is something very striking for us, is this knowledge we have that if people are remaining in hospital beds when they're fit to move on, actually 10 days in a hospital bed can be the equivalent of 10 years muscle wastage. So our problems in not moving people through the system and moving people on to care where they need to be supported is such an important issue for us to get right. And clearly us using the technology and support to enable us to cover more and more patients and give more and more assurance to people that they know they're being supported.
Thank you. So I've been a GP for over 35 years, and one of the things that has become increasingly apparent is that there are many people who, for one reason or other, end up in a hospital bed when if you step back from the situation, you realise that they could have been managed differently. So Diane's alluded to people being in hospital for longer than necessary because of care arrangements that take time to set up. But I'm also talking about people that perhaps could have been cared for in a different way and not needed to go into hospital. And this film clip is just an example of one of these situations. So there's a few film clips in my presentation. So this one I'm just going to play, and then I'll just talk a bit more after that.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And I said, well, just thought it'd be good companionship for you, nice and be together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The Liaison Hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The Liaison Hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
As that slide behind me shows, there's three strands to this approach, which is that, first of all, the effort to get people through and out of hospital beds into more suitable care settings is really very important. Then there's the ability to prevent people being admitted in the first place if there were more community support services. And finally, the patients are cared for in the best environment for them. And I would like to cite two examples that there have been in our area. Many of you may have heard of the Abingdon Emergency Medical Unit. This was set up over 5 years ago now, and allowed GPs for the first time to be able to, for people who you were worried about, were considering hospital admission, but felt that it wasn't absolutely, possibly always necessary, they could go to Abingdon, be fully assessed with same-day tests, get clarity about the diagnosis, the problem you were dealing with, get instant treatment, and very often with that system in place, be able to go home with some care support. It might be hospital at home, or it might be a review in the Abingdon Emergency Medical Unit the next day. And so this was a model that showed that you didn't have to have bed-based care in order to solve a lot of the problems that were presenting very commonly to GPs. I think the other example more recently has been the county-wide initiative to tackle the people who are staying longer than necessary in hospital beds because of the lack of support services and care services at home. These have traditionally been called delayed transfers of care, but a collaborative initiative enabled a lot of such patients, in consultation with their families, to be moved into intermediate care beds in care homes, where they were supported either by their local GPs from local practices, or more commonly from a clinical support hub based in the John Radcliffe Hospital, having close links with the nursing staff in the nursing homes to manage these people in a different way. So their rehabilitation continued, as the film implied, and they went on to whichever care setting they would have been, but they weren't occupying a hospital bed during this period of rehabilitation and onward movement. So it has shown that these alternative systems for managing hospital beds can actually work. And what we're trying to do is change the chicken and egg situation, where we're spending more and more on hospital beds, which means you're more and more constrained in trying to develop alternative services, and turn that round, that we can free up some of the hospital beds and then reinvest in the community services that we really believe, and based on good evidence locally, can actually enable much more care to be developed in the community. And in the case of Horton, there's plans to expand the amount of planned care there. Now, planned care is everything that's not an emergency. When you have to go to hospital, maybe a GP has referred you, that's the usual route, and it's scheduled treatment, might be for more investigations or actual treatments or surgery, for example. All this counts as planned care, and we know that more could be done up in the north of the county using the Horton facilities, which would be more convenient for many people up in the north of the county. So these sorts of changes enable this shift in the way we manage things. There is a film around planned care, but because this relates mainly to the Horton services, we weren't going to play it for you at this moment in time. But just to summarise, that it's been estimated that about 60,000 odd more appointments could be given up at the Horton if these services are designed in this way, with many more diagnostic facilities than at present. So moving past planned care and our preferred options there, we're moving on to stroke care. Now, stroke care has changed a lot due to new technologies and new treatments over the years. As you may be aware, it's very important that anyone who's having a stroke gets to an acute hospital setting as quickly as possible because of the clot-busting treatments that they can be given. And now there's also a new technique where clots can actually be physically removed with a sort of fishing net. I'm trying to be descriptive here. So that's called a thrombectomy, but never mind that. But the point is that actually acute stroke services are highly technical now. They need to be done in very specialised settings with a lot of the right staff, which is not just the surgeons and the interventionists, but also the multidisciplinary teams around ensuring that every possibility of stroke rehabilitation is explored early on. Now, at the Horton, there has been a stroke unit. It wasn't ever designed for the really acute stroke victims, but for people who were presenting a little later. But nonetheless, evidence has shown that such people, their rehabilitation is likely to fare better in a larger, more dedicated stroke unit with a wider range of facilities. So the proposal is that that people will move to the John Radcliffe. And this clip that's just coming up now goes over some of that.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
So at the moment, about 600 people with stroke are admitted to the John Radcliffe a year, about 100 or so a year to the Horton. And the proposal is that those 100 would be all treated in the central John Radcliffe Hospital, but those from the north of the county would be relocated back up to the Horton for their early rehabilitation. And the early supported discharge that's talked about here is would be an extension of the current scheme that runs in Oxford and Bicester, whereby people who are not too severely affected by their stroke but who do need rehabilitation and physiotherapy can receive that in their homes. This has been shown through numerous studies to produce better outcomes for people, and of course it releases hospital beds. So that's the story on stroke. Critical care, so this is intensive care, and it's traditionally 3 levels. Level 3 is those who need the most intensive care support, so they would certainly be needing artificial ventilation, for example. As you can imagine, this is a highly technical field, and although it's proposed that level 1 and level 2 intensive care would remain at the Horton, because of the level of expertise required, it is considered it would be much better for all those patients in the Horton who are currently managed there would be managed in the John Radcliffe instead. This is fairly small numbers that would need to be transferred. Again, there's a clip around critical care, but because it's mainly affecting the Horton, we'll skip over that, if that's all right with you, and come on to maternity. Now, maternity services, again, are the consultation document really mainly involves those living in the north of the county and the services around the Horton, as I'm sure you're all aware. Nonetheless, we thought we would show you this film because the principles that apply up in the north apply across the whole county, and of course are relevant to the midwife-led services that we have in the south of the county. But this clip is making the case, explaining why we need to do something different for maternity services in the Horton.
We want to provide a high quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of 2 groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. there's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex. And actually, as the health service developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
So at the moment there are about 1,500 deliveries a year at the Horton. That works out about 5 a day. Probably at any one time 80% or 70% are going to be quite uncomplicated, and it would therefore, as you can see, mean that you're providing consultant obstetric cover 24 hours a day, 7 days a week, 365 days a year for an extremely small number of people. And when we're faced with sustainability issues, both in workforce and finances, then we do have to question where we best put those resources. Quite apart from that, there are huge difficulties, as you've heard, in actually finding people who would want to do that sort of job. Hence the way the decision was made when there was no longer any possibility of doctors doing sessions up there under their training. The training status of doctors in the Horton was removed by the colleges who maintain standards in the profession. So there are many reasons why this decision has had to be made, but we feel that this is a safe one in terms of women will still have a choice, because those in Horton can consider going across the border into Warwick and North Hants if they need specialised care during maternity, or there's the John Radcliffe. And of course, for those of you in Wantage who are used to travelling big distances to the John Radcliffe, you'll know it's not so different for you down here as it would be for most up in the north of the county. So these are the things we'd like you to have your say on, and these are the ways in which you can do that. So all the consultation documents and some of the information behind it is at that website. You can write to pre-post address. There's a questionnaire as well, and obviously you can have your say in the forthcoming question and answer meeting. And there is a list of public meetings in your papers in front of you about elsewhere around the county.
Okay, lovely. Thank you very much. Just to let you know that the audio, the sound of this public consultation is being recorded. The other thing is the hearing loop is on. If anyone has any difficulty, let us know straight away. We've got technical people at the back who will make sure that that all works for you. So let's start then. As you've seen, the phase 1 is about the acute beds in Oxfordshire and the discussions around those. If you don't want to put your hand up and ask a question, if you would rather write it on a piece of paper, we have volunteers at the back of the room who will come around to give you a pen and a postcard, and you can write your questions there. If we don't get around to all of those written questions, the most frequently asked ones we will put on the website anyway. So who would like to start with some questions? Yes, great lady in the purple jumper, fire away. We'll get the microphone to you so we can all hear you. If you will be very kind enough to give us your name so we know who you're from and your question. Thank you.
Hello. Can you hear me?
We can, yeah.
Julie Mabberley, the Wantage and Grove Campaign Group. You mentioned some papers on the table. We don't have any.
Okay, our volunteers will get round to getting those. We're just going to hand those out to you. Lovely. Did you have a question as well?
Well, that was the first one. Without the
Okay.
paper, it's difficult to know what questions to ask about it.
All right. Would you like me to go to somebody else and then come back to you? Would that be helpful?
Yes, please.
Okay, thank you. There's a lady there with the baby. Bear with us. And give us your name, please.
My name's Catherine Foxall. I live in East Challow.
Sorry, could you just say that again? We couldn't quite hear.
My name's Catherine Foxall. I live in East Challow. All of the plans you seem to have seem to involve more things going to the John Radcliffe. How is the infrastructure in and around the John Radcliffe going to be improved to enable all of this extra stuff, particularly car parking? Which, you know, when you get a letter already, when you go to the John Radcliffe, they say allow over an hour for parking. It is a total nightmare. So how does this increase in capacity at the John Radcliffe get dealt with?
Okay. Peter, would you like to take that?
Yes, thank you. That's a really good question, because anybody who tries to get on site, sometimes they have to wait for half an hour or so just to get through the road. So we're currently working with Oxfordshire County Council and our colleagues in other parts of Oxfordshire to look at how we can improve access into the John Radcliffe. It's called the master planning process, which the county's working with at the moment. And it's going to address a couple of things, really. One is about the car parking arrangements on the John Radcliffe site, because there's, believe it or not, that's the biggest part of the real estate we own is the car parks. And actually reorganising those in a way which is sensible is part of the piece of work we're just about to go into. The second part is then the access route in. And, of course, that's really difficult. But if we can improve the flow by getting the car park right, then putting those two together will help. The other thing that we're also intending to do is also publicise the car parking information, so you can see it on a standard map and a website on a smartphone as well. So that will help get some transparency about where the best car parks are, where to park, what's the easiest route in.
Could I just add to that and just come back to you about your comment about it all seems to be about shifting stuff? I really want to emphasise that we're talking about moving up to 90,000 visits off the site up to the Horton. That's a really important number to hang on to. We're talking about moving 140 critically ill people of different kinds, some of whom actually are already coming to that site anyway. Obviously, that is a number. We don't expect all of the 1,400 to 1,500 women who've been delivering in Banbury to come to Oxford, and we already know that a proportion of them are taking up the opportunity to have a midwifery-led birth at the Horton site. And there will be some women, yes, who choose to go to South Warwick or to Northampton rather than come to Oxford. So you are right, we are moving certain services, but we're also making a very clear commitment to moving large numbers of visits off that site.
Okay, thank you. Lady with the blue jumper on, please. Thank you.
Hello, I'm Jim Stock. I'm Chair of Grove Parish Council. There are lots and lots of questions. The first one, why are we talking about the Horton? Nobody goes to the Horton from here. We're all JR. We don't want to know about the Horton. The second thing is that you haven't spoken about the vital thing in the hospital, food. Ask any of the patients that have been there. They tell you they won't eat it. It's rubbish. Get improvement on the food.
Okay. So what question would you like to put to the panel?
How are you going to improve things? Yeah, we've got no hospitals down here. And don't forget, Oxfordshire goes as far as Henley. What we're going to do? Can you imagine Henley trying to get to the Horton? You've got to be joking, haven't you?
Okay, lovely. Thank you very much. Who would like to answer that?
Yeah, so I think very, very fair points in terms of food and getting that right, and we've got a programme which is trying to address that, and that's with a colleague of mine who is working through that as part of his management of the site. But talking about the difference where patients from the JR going up to north of Oxfordshire, i.e. to the Horton, that will actually, as Tony quite rightly pointed out, release more space around the JR for further consultations that can be done there. It will help us in that sense. In terms of the community-based services and other services, I probably need to turn to Diane on that one.
Right. Thank you. So the relevance for here I'd come at it for 3 points. The first of which you'll probably be the least interested in, which is we are an Oxfordshire clinical commissioning group. We have one pot of money that we have to look right across Oxfordshire. So if we spend money wisely or unwisely in the north, it might affect the south. So we do need to consult with you about all of the things we're doing. In relation to impacts across this patch, one of the areas, the changes we're making around the beds and the changes that were proposed around stroke care, they do have impacts in this area. So the stroke care, we need to get to the point where we can have the early supported discharge, which is currently only available in the city and in Bicester. We need to get to the place where we can make sure that's consistent for all our population right across Oxfordshire. That will only be good news. That is about bringing services into people's homes and supporting people back direct from a far better and shorter, and we believe better outcome in the JR, with less likely to disability, long-term damage, bring people home, support them with the early supported discharge. The bed-based changes that we're making, and we've got a lot more to do because we've still got an awful lot of people waiting in beds who are fit to leave. But the things we've been doing to support people out and bring people back out, that impacts here. So Julie, when she was talking about the bed case, we are talking about care homes locally, support to people locally and bringing people locally. So we acknowledge that all of what we're talking about today won't be of interest to people generally, but you need to know we're doing a good job right from Banbury down to the south in Henley, and we need to talk to you about all of those things. We'll try and be proportionate in the amount of time we spend on things, but it is important you have your say because you will get some of the benefits, and certainly if we don't get it right, you'll feel some of the impacts, and we wouldn't want that.
Okay, can we just bring in Dr. Julie, who's local GP?
I think I was just going to make the point that I think, just in case there's any impression that's been given that people from the south of the county would be expected to go up to the Horton for routine care, I don't think there's any intention about that. I think that it's simply that the services in the Horton would be expanded to meet the needs of the people in the north of the county, which of course will then free up a certain capacity in the central Oxford site.
Lady in the purple jumper.
Yes, thank you. I'm County Councillor Jenny Hannaby. I was going to leave my comments to the end, but I think you need to understand the fact that you've split the consultation is causing a lot of unnecessary, confusion. Yeah. Confusion. Because these good people here, majority of them might at some time in their lives, and I was here in 1950, use what we call the community hospital, which has been closed down due to Legionella, which isn't there. 5 months on, it's still not there. I have come to speak to CCG, if anybody does remember me. I have asked, could you please reopen until such times as you do make your mind up what is going on? Because for everybody, we should have had a consultation in October. That has been put back now till November 2017. And I think that's shocking. However, we are where we are at the moment. And what I have read everything. I'm an avid PCT goer before the CC commissioning, so I do know about the changes that you're trying to do. But at the end of the day, we have not got the money, and the money comes from government, and we should be really knocking on their door to say we haven't got the money and our services are really going to suffer. Now, I think, ask anybody, do you want your be in a hospital bed or at home? They're going to say at home. Of course they're going to say at home. And that is what we want. You have not got the staff. We know that we know that there's bed blocking gone back to about 168, is it?
161.
Well, 161. Well, 5 years ago, when I was first starting looking at the bed blocking issue with the county council, we were trying to make promises that we'd get it down to 74 or so with joint working, and that's not happened. So we're back to where we were 5 years ago. So whilst you're putting in all these wonderful efforts, we've still got an issue, and I think it's reablement. Now, Wantage Hospital used to take stroke patients. We had a wonderful reablement team. We had 18 beds down to 11, down to 12, down to 11. We had a 30-bed hospital, and we still, thank you, have got a maternity, midwifery-led, admittedly, but it's a wonderful unit. So down here, we do know what it's like to have these services, because we've used them up until July of last year. So I think what you need to take away is, whilst Horton, and I do have to have sympathy with Horton, I really do, because they have had a Rolls-Royce service and now it's being reduced down. So I do have sympathy there. Also, I must say, we've got new housing coming. We have probably got about 1,000 houses just been built, and we've got another 5,000 that's in the pipeline. So to have nothing in Wantage, like our community hospital, the service, and our doctor's surgery, which disgracefully was turned down for the money that they put in. They were totally misled, I believe, by NHS England. And we must try and do something about that, but that's parked somewhere else.
Can I just ask...
So all I'm saying is, the question is, I think it's wrong of you to have split the consultation, because this is the confusion we're having now. Why are we talking about the Horton? Why are we talking about Banbury?
So your question is, why the two parts?
Well, I know why it is, but maybe
That's
you'd
the
like to
question
explain it to the
panel.
people here.
Thank you.
Thank you.
Diane.
Okay, thank you. I think we would ideally have done everything in one go. I think that, you're absolutely right about being able to see everything in one go. But there is so much to do in terms of thinking of how we want to develop services in each of the localities. As has already started to be illustrated this afternoon, each locality is very different. It has a very different sort of set of resources, layout, rurality, whether it's a city-based or other. We need to get that engagement with you, with each locality right. We need to get that design of the services right. Meanwhile, we have some really pressing challenges, mostly of which are affecting the north of the patch. We have a temporary closure in relation to the obstetric service. Maybe Tony or others could elucidate some of the challenges that creates for day-to-day management of those services. But we can't give certainty for people around what the future shape of employment opportunities and other things will be unless we can resolve the maternity, the obstetrics shape of services. For stroke, I personally, and I'm sure the clinicians will feel even more strongly than I do, it is not acceptable for us to keep knowing there is better care that we could offer to around 100 people a year and not offer it. And the sooner we can do the consultation and reach the conclusions around stroke and critical care, the quicker we can get the right care into those individuals. It might be in total 150 people, but those 150 people really, really need us to give them the best care. In relation to the bed side of things, this was something we started a year ago. And we were asked by the scrutiny committee, the overview and scrutiny committee from the council, to take this to consultation. They didn't like us to continue to have a temporary arrangement. They're very keen that we get this resolved on a long-term basis. So absolutely, if we could have everything laid out in one place and we were ready to do that, we would have done. However, we have a series of real imperatives, whether it's delivering the best care for our patients or making sure that we can make permanent the things that we're being asked to around the bed changes. And then we need to do a really good job of the rest of the services so that next time we're talking to you as part of the second phase of consultation, you really feel confident that we've done the work with the local GPs, with local counsellors, with local planners around what we could deliver. And we wouldn't be able to get to that place swiftly enough to deal with the emergency changes in the north.
Okay, I'd just like to take a couple more, 4 questions from the floor, and then we're going to move on to the round table so you can talk to people face to face. Ali Green, who's over here, will explain how that's going to work. But if we can quickly run through those 4 questions now and then move on so you can actually talk face to people. I promised the lady over there with the dark hair and the polo neck jumper first of all, and then there was another lady. Yep, at the back. Great. And two more. Yep, got you.
Hello, Julie Mabley again. Right, now I've got the papers in front of me. Acute hospital beds. Now, the idea is you're going to move people away from the hospital beds as quickly as possible and give them specialist care close to home. Is that correct?
Yes.
Right, well, where are you going to get that specialist care? How are you going to provide it in this area, which is 60 minutes drive from the JR and the services of the JR? And if you're talking about care homes, which care homes around here have the quality of care that will be necessary to provide that rehab services? Because you've closed our local hospital temporarily last July, which had those services, and there are no more that I know of around here.
Okay,
that's the first question.
That's fine. Just bear with us because we have to get through the other people who've got their hands up. The other people who had their hands up, are your questions related to what the lady has said? That yes, that's a different one. Is yours the same as?
Yes, mine's related to the cost of all these things that you're not talking
Right.
about.
Let's put the cost together with the other ladies. Hold on for 1 second. We'll get a microphone across to you. And I haven't forgotten yourself there. Just bear with us.
Yes, I'm Maggie Swain, Secretary of the Wantage Hospital League of Friends. My question is all the things that Julie's mentioned, all these different stages, you want people to go out to their homes, you want to be looked after their homes. Who pays for all this? That's what I want to know. Where's it stopped from? The NHS pays to it? Does it go to the council? Does it pay for it? When would I end up paying for it? I live on my own, so therefore I'd have to be looked after if I had a stroke or something like that at home, 24/7. I have to say I wouldn't like to be on my own the whole time because I'd be depressed and get lonely. But I'd like to know where all the costs are in all these things, and it's not just passed on to somebody else.
Okay, so we're talking about the costs, we're talking about the 60 minutes from the JR to here, and about care homes. Where will people end up? Okay, and staffing, Tony.
Yeah, so let me start. The first thing to be really clear about is that there's no discussion in terms of this consultation on bed release. There's no intention to place people into any environment other than the hospital if they don't need to be in the hospital. Our problem is that because we have very poorly developed facilities for assessing people in their own homes, for responding at the right time with enhanced support, we tend to use hospital beds for anything where there is a general anxiety that that person might not be going to manage, might be going to be at risk, is unwell, and we can't quite work out what to do with them. And the changes that have already been happening, and not just specific to Oxfordshire, but within acute medical care, have already been challenging those kinds of ideas. So we have to, as a population, rework some of our thoughts that a hospital is a great place to put somebody when we're a bit worried about them, and actually recognise that if that's what we do, we will end up having them in hospital, giving them all sorts of treatments and tests, and then discovering that we've already so messed up their mobility and their confidence that we can't get them out quickly, as a result of which they're stuck in hospital and then become progressively less fit, prone to falls, confusion, incontinence, infection, and a whole range of difficult problems. So the issue is not that somebody is gravely ill and we're not going to admit them. The issue is that we want to be able to get the right people looked after in the right way, at the right time, in the right place. The movie that you saw was about describing the activities of this liaison hub and the ambulatory care unit, and these things are already in operation. We've already put over 500 patients through intermediate care beds, kind of long mouthful, isn't it? But what that means is beds in a nursing home where they get enhanced support from mostly our staff, physiotherapists visiting, nurses coordinating the care, medical input if necessary, and a telephone support system. And what that means is that those nursing homes who we've worked with quite closely, and I have to tell you, it's been a revelation to us in the hospital, to medical staff, to discover how highly motivated and competent many nursing homes are able to be in this context. And they will ring up and they'll get through to our hub and they'll say, got a bit of a problem with this patient who you sent home 3 days ago. They'll get advice. Our team can work out if they need a visit. Now, those are patients who might formerly have simply been sent back to hospital. by the nursing home, or maybe even by the GP or the district nurse if they had got home. But we now have a process where we can provide support at a distance and work out for each individual patient what kind of support they need. Now, what we have discovered by doing that, by putting that in process, we do not need as many beds in the hospital for those patients to be stuck in. We recognise that doesn't make an instant difference to some of the difficulties about getting into the hospital. When there's a big surge of really ill patients, there can still be long waits in the emergency department. But in terms of who needs to be in a hospital bed, what we're already discovering is we don't need as many beds. And that's applying also to things like planned care, where with differences in how we do anaesthetic, in how we get people prepared for their surgery, in terms of what it is okay to go home with, we're discovering actually patients are much better off when they do that. So, for example, it's quite a bleak sort of example, but we used to think that if a woman had to have breast surgery for cancer, she'd have to be in hospital till the womb was all completely healed and that was fine. But actually, nationally, what people have discovered is you can teach women to look after a drain, and they can go home with the drain in. Now, to many people, that sounds really barbaric. But actually, if you talk to their patients, that's been great, as long as it's worked right and they're properly supported. So there are lots of things like that where we have discovered that our idea of what hospital is about and our idea about how we're involved in looking after ourselves, it can change and actually can be different in a good way. And it's really important that we recognise that, because what we're looking for is what gives you the best outcome at 1 month, what gives you the best outcome at 6 months and a year. And I think what we're discovering, and we're not unique in this, is actually reducing our reliance on putting people into a hospital bed is part of what gives you better outcomes at that longer time interval.
Okay, Pete, would you like to come in?
Yes, sorry. Hello. Peter Grant. So I work for Oxford Health. One of the services that we have within our directorate is the Care Home Support Service. And this is a service that has been working with colleagues that Tony have been describing, supporting patients through what the care home beds that are managed by the liaison hub. And I think you've seen a reference to that within the clip within the film. There are two things I would like to comment upon. One of those is really just a reiteration that we have a growing sense of understanding that frail patients, usually in advanced years, often don't do well in hospital settings. But it's not in spite of what we're doing, it's because of what we're doing. Okay? And I think that was a point that was made within the film, but I think it's worth reiterating. The other thing, I think, so Julie, your question I think that you'd asked was, what about where are we going to get the care within these homes? I think that's a terribly good point, and I think I'm really pleased that you brought that up. What we've noticed about the support that we have through the Care Home Support Service and through our colleagues within the Liaison Hub is that when you have one patient who's been supported within the Liaison Hub, what we've often found is two things. What we've often found is that the other patients within those homes are benefiting from the input that we're having for that one. Because you influence the competency within the staff, you influence their confidence in how to manage patients with complexity, because they learn from the advice and the support that you've had from the one patient. And I think that's a really, that has been something which was an important learning point that I took away from what we've found in supporting patients in this way over the last year. But it wasn't, it's what we would have called an unintended consequence, because we didn't set out knowing that was what would have happened, but we've noticed that it is happening. I think it's an important point. And I think you're right to point out that if we want to be supporting patients within the homes, within their own homes, we need to develop the infrastructure to be able to do that. And we also need to be able to unlock a lot of the resources, and some of those resources are often tied up within acute care, because that's the model which we've had. And Tony and Julie both touched on two important areas, which were the development of the Liaison Hub, the Adams Ambulatory Unit within the John Radcliffe, and the development of similar units in Abingdon through the Abingdon EMU. They're designed to try to change the model of care so that we head off the dependency that often happens by trying to treat patients where at all possible in our own homes and supporting them. And we know that patients do better within their own homes if you can keep them there and support them there. So I think this is very much about building upon the steps that we've started, learning lessons from that, both the intended things but also the unintended consequences. And we, as a trust, are as committed in working with partnership with Tony and his colleagues, but also our GPs, to make the changes that are required within the models of care, such that we're able to head off dependency before it's there.
Okay, Peter.
And just to say, we're also thinking about the technology you can deploy to do that at your own home these days. So we've seen that we can monitor things like blood pressure, and we can monitor people's INR readings. That's the reading when you've got warfarin management. So we can do all of that remotely, and those sorts of bits of technology will help us deliver these types of care. Just to pick up the question of cost, because there's 146 beds that are not in use currently, and the expectation is overall we'll get about 4.9 million cash released from that, which then we reinvest in services. So that's really where the sort of flow of funding has come through, and we're reusing that funding to really invest in these services, which are quite crucial.
Okay. The lady with the Alice band and the lady over there, are you happy if we put your question to the panel, the table you've got there, rather than to... No, you want to do it? Okay, that's fine. I'm just conscious of the time, that's all. But please, no, please go ahead, yeah. We'll just let the other ladies first.
My name is Marjorie. I come from the village of Buckland, where I'm a parish councillor. It is a small village. So when you're thinking about inequity, please remember the small parishes and those people who are farm dwellers. You spoke about stroke services being after hospital care, going to Oxford City and to Bicester. I am a Stroke Association volunteer. I'm an ambassador. I retired from the health service 8 years ago. I was a health visitor. NHS England commissioned the Stroke Association, as you will well know, 15 years or so ago, to take on much of the role of the NHS. Stroke Association has been doing a gallant job in education, prevention, promotion of health, research, and the provision, most importantly, of speech therapy when people come out of hospital. Why, therefore, is NHS England and County Council reducing funding to the Stroke Association? Where will support for people when they come out of hospital go to, knowing that the increase in the demography and the epidemiology for stroke is exponentially greater after the age of 70? And also knowing that the best effect from care for speech therapy, I'm referring to in particular, post-stroke, and also physiotherapy for getting people ambulant again, is within the first, is it 2 weeks? Is it 6 weeks? Is it 18 months? Is it 2 years?
Okay, thank you. Let me just go to the other lady as well. As I say, I'm conscious of time, but we have got your question to come to you.
Firstly, I'd like to say that I'm glad to hear that you're learning from different cases, because...
Would you mind, be very kind and tell us your name, please?
Joyce Hutchinson. I have a friend who was bed blocking. The only way for her to come out of the hospital was to go home. She's been home and she's had care at home, which has been appalling. She is in such a bad state now, she is going to have to go back into hospital. I'd say, please, the people you are getting to do this caring, see that they're properly trained. But my main question is, I've just recently been into the JR, and I can't thank the doctors and the nurses for the fantastic work they're doing under the circumstances. And I would question, how much management is there in the hospitals? Has that been looked at? It seemed to be crawling with managers. And what sort of expenditure is there being spent on managers? That needs looking at.
Okay, lovely. Let me just take one last question from the lady in green over there who's been very, very patient. Would you please give us your name?
My name is Jean Loudon. Can you hear? I have two questions, really. The first one was when the gentleman talked about the excellent relations with care homes and how they did it. Was he referring to any of the 4 homes here, and if so, which ones? First question. Second question about care and the comment that care was poor. I think that it's been a lamentable lack of links between the health services and the social services, and there has been no effort that I've known of an effort to make caring a proper profession. It is something that is people will pick up and will learn and will do the courses, but frequently when they are old or recently retired, and it should be a proper profession with good standards.
Okay. If we can keep the care homes, the specifics about the care homes to the round table, that would be great. But basically, it seems that both the lady from the Stroke Association, Joyce over here, and yourself are concerned about aftercare. So care after you've had either a stroke or had an operation. And we'll also talk about management as well. So just very quickly, Diane.
Okay, thank you. Thank you for the question from the Stroke Association. There are lots of dilemmas that we have as a clinical commissioning group about where is the evidence for what things that we should purchase. And I know one of the conversations we've been having with the Stroke Association is about some of the aftercare and can we demonstrate the changes. It's certainly something we're looking at. We need to complement the services that we're buying from the supported discharge going across the whole of the county, also supported by other voluntary sector services. We will continue those conversations with the Stroke Association about where we can demonstrate the greatest evidence. Can I just quickly pick up the home care challenges as well? We do talk extensively with our colleagues in the County Council about how we can grow our strength in the home care service, how we can have confidence in the home care workers, and indeed how we can find sufficient home care workers, which I'm sure you won't be surprised is a challenge across Oxfordshire with the nature of employment that we have. The social services have worked with us extensively to demonstrate both an increase in the number of home care hours, but also to streamline the number of places we buy home care from, or where social services buy home care from, and we also buy some home care for people who are demonstrated to have NHS needs. We are working with a more limited number of home care providers with a view to really putting some more support alongside them, investing more in those home care providers, making sure those home care providers are looking after their care workers. We have a long way to go, absolutely have a long way to go, but is very much recognised as such an incredibly important profession in supporting our health and social care services that we are working with social care exactly about how we can work with home care providers, see it as a partnership with ourselves and home care providers in the same way as we've had some successful partnerships with a number of care homes. So I think that was my questions. I'm going to hand over.
Pete, no, you're fine. Okay, Tony.
Really happy to pick up on the management question as a clinician. So I think what I'd say is that it's important to understand that a complex set of services does require some degree of management. Some, absolutely. And the more complicated the pathways the patients are moving along in the context of what we all have reasonable expectations of, which is that quality will be upheld and preserved and budgets will be kept and all the rest of it, actually the more you require there. We have about 8,500 frontline staff, and we have something of the order of another 2,500 or so who we would not call frontline, but those include lots of people doing straightforward administrative support type jobs. There is clearly a group of people doing nothing but management. There are quite a large number of clinicians who have management responsibilities as well. So I think when we talk about management, we've got to be clear that there is a join up between clinical activities and how that is kept going, and all of the things that we have to do to fulfill our statutory obligations to you around how money is spent, to get the staff paid, to get people hired, and to meet our regulatory obligations as well. So there is a burden. We don't invent it. We do absolutely respond to it.
Okay, we're going to move on now to the round table. Ali, just bear with us. Ali Green's just going to explain how that works, because it's now 4:15 and I'm very conscious.
I haven't answered the question that Jean asked.
Yes, I said that would be discussed at the round table. It's better, that one with the specifics is probably better face to face. So let Ali explain how that's going to work.
Okay. This is only the third of 13 public meetings that we've got going ahead across Oxfordshire, and it's the first time we've tried to do it in this way, so do bear with us a bit. I'm fully expecting that at the end of the afternoon, when you leave at 5 o'clock, there will still be some questions that we haven't managed to answer today. And so what I will make sure that every single table has some postcards that you can leave questions with us, and we're making sure that we're doing a question and answer sheet on our website. There's also a survey that everybody is encouraged to complete. Either you can do that here before you leave, because we've got some paper copies, but it's also available on our website, and we'd encourage everyone to do that. So it is 4:15, and we do need to leave the building by 5. So it doesn't leave us a huge amount of time to do some of the round-the-table discussions. But we're going to have a go. What I first need to do is check that every table has someone who is going to be writing things down. So there's a scribe and someone who's going to help do some facilitation. So if you just bear with me. Joe and Richard, I have you here on my left. This table here, Roger, Steph, would you join this table? Excellent, to work with Roger. This table we have Lorcan and Fergus. Behind that we've got Louise and Francine. And then in the centre we've got Anne and Ali, and then we have Peter and Julia. The back tables, just if you just pause a moment, just wait a moment before we start talking. Thank you. At the back, Julie, can David support you at that table? David, is that okay? Thank you. And then I've got Catherine. Would you be there with Tricia? Is Tricia around to support you on there? Oh, Tricia, you're with Paul, are you? Is Lucy's going to support you? Okay, that's great. So we've got 2 people at each table. You have some very broad questions that we're asking of you this afternoon, and they are broad just to allow you to be engaging with us and all sorts of things. I see people are really keen to do it already, so I'm going to let you start. We will have our panel members who are available to support if you need it, and have fun. Thank you.
Hello, ladies and gentlemen. Just to let you know, it's 1:45 now. If we can look at wrapping up in about 3 or 4 minutes, is that all right? No? Who's a no over there? So 3 or 4 minutes, please. Thank you. Okay. I did have. There we go. That's fine. Okay. All right. Hello, if we can draw to a conclusion now, please, if that's all right. We can come back.
It's a summary, and it has a survey.
Oh, right. Summary and survey, yeah. Okay, we're wrapping up now. We'd just like to get a couple of questions and summaries from the tables, if that's all right. Lady over there, hold on for one tiny second. Just to say, behind me here, if you can see, is You can find out more about how to have your say. Obviously, we've had the public meeting today, but also the consultation documents here, and there's also the big consultation here with a questionnaire as well. There's the website where all the consultations are available. You can complete the questionnaire, or attend a public meeting as well. All the written questions that have gone round, they will be collected up, and the most frequently asked questions will be put on the website with the answers. I'm looking to Ali now. Just going to say yes, yep, that's fine. Okay, so just to summarise, the tables where nobody asked a question, just for time-wise, I'd like to go to them and the lady over here. Bear with me for 1 second. Hold on, we'll get a microphone to you. Oh, here you go. Just use this one for the minute. There you go.
Thank you very much. It's Jean Numprice from Grove Parish Council, and I just wanted to ask, because this consultation is happening well ahead of the bits of the consultation that we here are probably more interested in, namely the community services, GP and so on, and we don't really want them to be taking place in two silos. We note the interdependence of those different parts of the care spectrum. Please, can you ensure and assure us that the interdependencies will be taken care of? We will be asked to look at how what we say today affects the later consultation and vice versa. Please don't conduct them in silos.
Thank you very much. Okay, just hold on.
Hi. Thank you for that question. We have been very careful to make sure that the things that are in phase one that we're really needing to make significant change on are completely discrete from those things that are in phase two. Now, clearly, people are people. They will use services, and they will use services that we talk about in phase one. They'll talk about services in phase two. But we have been very clear. So, for example, even down to the anaesthetic rotas, making sure that we don't affect anaesthetic rotas that would have any long-term change at the Horton. So we are very much making sure that there isn't an absolute dependency between the two consultations, but we are delighted to hear the sorts of things that we're hearing today, which then inform our thinking for the next phase of consultation. So we will try and take that, and particularly the learning from events like this in terms of how to frame things in those areas. But they are actually not interdependent. There are clearly patients who use both services.
The table here, is there anyone here who'd like to ask a question or to sum up the general feelings of the table? Okay.
On our table, we're answering the questions. Have we made the case for change clearly? It was felt there was a reasonably made case and recognised the change of practice to keep out of hospital as being a positive thing. The problem is aftercare. Needs to be dealt with. People need to hear more about it. What is there that is tangible? Where are the nursing homes, care homes locally to meet the new need? On the next question, how would the proposed changes impact on you and your friends? Have even today problems getting to and from the JR, parking, etc. When are these going to change? Park and ride is not an answer. GPs are struggling, and this is putting more pressure on GPs locally. We can even foresee closing of lists. Because they're struggling, they may not have the capacity to take into practices new diagnostic systems and so on. However, we recognise that we are lucky compared with other areas of the country. And on the final question, do you have any suggestions for how we might mitigate the impact? We need a new mechanism for how people can contribute to their personal treatment. The main problem is national underfunding. It could be taxation, it could be insurance, it could be various things, but it was just raising that we need more funds to go in. We need also to combine NHS and social care to be more effective. We need better discussion with patients as to the options that they have when they're with their GPs and also with their consultants. We need to educate the public on when it is appropriate to go to A&E, and we need the IT systems between GPs and consultants to be able to communicate more effectively than has been seen locally.
Okay, lovely. Thank you very much. Obviously, all those questions, we can't answer them right here, right now, but they will be taken away. But I think that Peter does want to make a couple of points, which hopefully will help.
So I think two things. Certainly the table I was at the back, car parking was a very clear point. And I understand that the JR originally had a multi-storey car park approved in its original planning permission 40 odd years ago, and of course that has gone now in terms of the sort of 5-year rule. So we are going to, as I say, work with the County Council on thinking about the master planning process of how we look at that and get that right, and that hopefully will start to address that. And in terms of the IT system side, yes, we're working. In fact, actually tomorrow we've got a meeting about how we start to connect some of these things together, because you're right, getting the technology, so the bits of care are connected electronically, so people can know what's happened in your GP practice, what's happened in your community services, and also what's happened in the acute sector is quite crucial to this. In fact, we won £10 million to accelerate the adoption of this across the system recently, and that's been a really good injection of cash to speed that process up. We know colleagues in Oxford Health are bidding for another 5 million to support that as well, so that's to be wait to see the results of that, but there's a lot of investment in that area happening.
Okay, that's lovely. And the table over here on the left, I don't think anyone here asked a question beforehand. Would you like to summarise or ask a final question?
Medical notes. Yeah, I think we had a great discussion actually, which is I totally agree with, and it's similar themes as well actually. So the case for change, I think there's general agreement that it was made as a generality, but not specifically for this area. So there was a gap there. A lot of discussion about the need for proper care in the community, both before discharge and also trying to prevent discharge, having more therapists and more carers and more support for carers and support for families and links to GP practices to be able to do those things. So it was very much focused on the community side. And there was quite a lot of concerns about transport to the JR, transport to hospital appointments, the lack of public transport and the lack of support for volunteer transport as well. So, very similar themes in a lot of ways.
All right, thank you very much. If you have written a question on a postcard, please make sure that our volunteers have that, because we will be putting a list of frequently asked questions and the answers on the website. Do get involved. Thank you very much for coming this afternoon.